Minette for UW Oshkosh DNP program. This is Luke Minette for the UW Oshkosh DNP program. I'm interviewing Andrea Schneider, one of our dermatology NPs. So I'm very thankful that she took the time to do this today. So just go ahead and let you introduce yourself and kind of talk about what got you into medicine and why specifically like specialty care.
Absolutely. Well, thanks again for having me, Luke. Like you said, my name's Andrea, and I'm a nurse practitioner in dermatology with Ascension Medical Group. I've been working in dermatology specifically for a little over 10 years now. I was lucky enough to train with a private dermatology group shortly after graduation, and they really just took me in, and I was able to learn so much in a very short year. And I've been working locally in the Appleton Oshkosh area for the last little over 8 years. And I initially wasn't going to do patient care. I thought I wanted to do the administration side of healthcare. And then as I got more into patient care, I realized that that's where I really needed to be. And having gone through a personal history of psoriasis, acne, warts, I had to have facial surgery due to a dermatologic complaint when I was younger. It really just felt like it fit for me. And what I love most about my job is that I get to do something very medical, surgical, cosmetic in the same hour. And I can go in and out of each room and I never know what's going to happen throughout the day. And I just love that.
Great. Yeah, a lot of the students are family practice and going into primary care, whether pediatrics, family medicine, or internal medicine, but some of them do have questions about specialty care. So, talk a little bit about, what it's like to actually actively practice in specialty care.
Oh, absolutely. So one of the things about what I love about family practice, internal med or dermatology, is that you can really become your own clinician and really decide what you want to do within that practice. And the great thing about dermatology as an NP, I have a lot of autonomy and I'm able to do most of the procedures that the doctors do. I like to focus on smaller procedures and I think I do them very well. And then for the larger scale, I say, no, the doctors can do them and we work really well together. And I think in any specialty, especially family practice, if you decide to make your clinic procedural, you can, that's the fun thing where you can decide what you take on and what you don't take on, what you pass off to someone like me and so on.
Great. Well, good. I know you have a number of topics to kind of discuss, so I'll let you go ahead and get started with what you'd like to talk about today.
Absolutely. So some of the things I'd like to talk about today is that I'm going to focus on some like moles and skin lesions, and then I'll get into more of like the bread and butter of dermatology, psoriasis, eczema, acne, and then some rashes and things to look for, when to refer, and some of like things that I've picked up along the way that I'm really happy that I learned. Sometimes you wish you would have learned it sooner, so I'll share some of those things as well. So first things are moles and skin lesions. So the first thing, most people think of is skin cancer. And I find that a lot of new grads, when they look at skin, they're like, okay, everyone has skin cancer, let's refer to derm. And I don't think that that's a bad idea because I think the referral process, pardon me, you can learn a lot from that by then reviewing those records after to really see, what other people do. I still do that when our department refers out to an academic or university level. We always review those records and say, okay, I can initiate that in my practice. I can do this treatment next time, things like that. And moles and skin lesions are no exception to that. So to highlight, yes, we have the ABCDEs of melanoma. That's the most important thing. Asymmetry, border, color, diameter, and things that are evolving over time. I always tell everyone, go with your gut. If you think something looks concerning, send them our way. If you're comfortable doing the procedure yourself, go right ahead and take care of it. besides the ABCDEs of melanoma, I also have my own method, and that's the ugly duckling method. When it stands out, it's coming off. Aside from your traditional ABCDEs of melanoma, you want to focus on things that are pink, crusty, shiny, bleeding. Anything that's standing out from everything else, you really just want to get them to dermatology unless you're comfortable with doing the procedures and doing tangential or shave biopsies or punch biopsies, things like that. One thing that I will tell people for urgent referrals, if you think that someone has a melanoma, call us, send an urgent referral that, rule out melanoma. We are really, our department specifically, and I think any dermatology group can say that they do a really good job of making sure that if there's a concern for melanoma, we get them in and take it off right away. That being said, other things to look for, especially like in kids, there's not a lot of common skin cancer in kids. But if you get a kid with like a bleeding mole, or they develop like a black mole, even like in a few weeks, send them on in, make sure we're seeing them pretty quick, because we want to take care of something small in those little people right away versus making it a larger procedure. Any questions about that, Luke?
No, not necessarily. Yeah.
Okay. And then the biggest thing that I tell people is, as you start, doing your physicals, or urgent care, depending what you focus on, you're going to see a lot of common things. And some of those common things that just become familiar with the words, probably the biggest one would be a seborrheic keratosis. Those are those like big, brown, crusty, scaly overgrowths. It's okay if you send a referral and for a rule out melanoma, and I respond back saying it's just a keratosis, it's nothing to worry about. That's okay. That's how you learn, and it's better to be certain that it's not a melanoma. They can be tan, they can be gray, they can be pink, they can be all types of colors. So it's really important to make sure we're not missing those two. Precancerous lesions, or also known as actinic keratoses, are oftentimes what you find in like around 35 and up, but the older the patient, the more common you're going to see lesions like this. And that's where you're going to get like the pink scaly patches, throughout the sun exposed areas, arms, chest, really any sun exposed, but the face is the most common. So again, just being aware of things like that. Cherry angiomas, those are those little red moles, or cherry papules. So there's a variety of different common skin lesions, many of which over time, if you guys decide to take care of those in your office, you can sometimes with liquid nitrogen, cauterizing, depending how advanced you take your procedural skills.
Mm-hmm. Yeah, I mean, is liquid nitrogen a reasonable treatment on some of those seborrheic keratoses?
Absolutely. The big thing with liquid nitrogen, I use it. It's very rare. I don't use it in a day. Liquid nitrogen is a wonderful thing. The biggest thing, and I'll probably highlight this again, is if you're going to spray something with liquid nitrogen, make sure you can own up to the mark you may leave that patient. I think education is key. Setting up the stage, I tell everyone, and I can be quoted at this, it's going to, it's so cold it will burn. It's going to get pink crusted, elevated, crusty, and then flake off in about 10 to 14 days. And it may leave a white to pink patch left behind. And I tell everyone that. I always make sure they don't have any big events coming up, because once it's sprayed, you can't go backwards. And I've learned the hard way that it's you need to confirm before you do anything. Sure. I tell people, I would say to people, if you're going to start treating with liquid nitrogen, seborrheic keratoses are a great place to start and learn, because you don't need necessarily a lot of liquid nitrogen. Warts typically take that 10-second freeze thaw cycles. You don't necessarily need that with like the thinner keratoses. Some of the thicker ones you may, but like on the back, people aren't really worried about the marks. I would definitely not start on the face at all, but like more of like the body, the torso. I hate to say it, but oftentimes some of the older patients are going to be less concerned about spots. So if they're bothersome, go ahead and treat them. Okay. Then we get into a lot of the different, or a couple of the different skin cancers. I'm just going to touch upon it, but things to look for. We're going to see a lot. You're going to see a lot more of these too: basal cell skin cancers and squamous cells. Now, you look more like pink, red, scaly. indurated, which means more like the divot to the area. But they typically stand out a little bit more. But again, if you're concerned about it, send it on over to dermatology. Okay. One of the big things that we get referrals for are sebaceous cysts, pilar cysts, and lipomas. So all of those are benign growths, as you would know. One of the big things I tell people, and for people to educate patients, if they're not bothersome, nothing has to be done. And the other piece of that, insurance doesn't cover the removal unless it's symptomatic. So if it's asymptomatic, I just tell people, well, let me know if it becomes, or it's going to be, this form of cost. And I think we get a lot of disappointed patients sometimes because they come to the office saying, well, my person or my provider said, oh, this should just come off. So come on in and get it taken off. So not only are they mad that we don't do a 45-minute excision on day, but that insurance may not cover it. So I can't stress enough the importance of setting up realistic expectations for patients and just saying, check with derm. It may be covered. It may not. It really depends on the reasoning. Okay. Let me just go to this. So my clinical pearls for skin lesions, again, if you're concerned, we're concerned, so please send a referral. We're always okay with that. I think I mentioned before, if you're going to start a procedural practice, just make sure that you're comfortable and can own up to that scar or like discoloration that you're going to leave behind. And education is the most important part to them. Always trust your gut if you're concerned. I can't stress that enough. Things to send urgently. I mentioned kids, if a kid comes in and they've got something bleeding on them, come on in. It could be a pyogenic granuloma, which aren't cancerous, but they can get very large very quick and it just becomes a bigger procedure. So if you see something bleeding on a kid, get them in. And anyone else, adults and kids as well. Ulcerating lesions, black, something growing or changing pretty fast. And then again, bleeding would be the biggest thing. Okay.
Yeah. A couple of questions. One, do you have a good recommendation for anybody that's getting into primary care and want to learn some of the procedures as far as like simple skin lesion removals? I don't know if there's any courses or, good references you have for kind of learning some of those simple procedures.
Yes. Let me just take a second. So there are a few dermatology conferences and groups. I'll make a note to look those up. I think it's Maui Derm. They have an NP and PA section. I think that they do like a pre-conference workshop where they will teach you how to do the basics. And I'm talking like, how to clean, how to, what kind of procedure, is it clean? Is it sterile? And then I think they'll go over the basics of like a tangential or shave biopsy, as well as, I'm so sorry, pardon me, like basic punch biopsies, things like that. Yeah, I think that that's the name of the group. I can get back to you on that one for further information. Yeah.
Yeah. The other thing is, you mentioned pyogenic granuloma.
Yeah.
I'll never forget thinking one time that something was a cyst and I incised it. It just started bleeding everywhere and it wouldn't stop. So I think that's a really, as far as assessment findings with the pyogenic granuloma, any tidbits there to kind of differentiate between that and like some other type of skin lesion?
Absolutely. So my nurses love when I describe a pyogenic granuloma. I get to say the word beefy, red, bleeding, and fast growing. So if you see one of those, it's likely a pyogenic granuloma or a very irritated, inflamed cherry angioma. But you'll usually get the history of it appeared rapidly and it's growing and it's bleeding. It may not be, they're usually covered with Band-Aids, I find, and it may not be bleeding when you're assessing it, but oftentimes with numbing or even like manipulation of the lesion, you're going to find that it's likely very easily going to bleed. Mm-hmm.
And that can be associated with pregnancy too, correct?
Yes. And again, just with the vascular nature in pregnancy, I've treated too many PGs in pregnant women. So, and
Okay.
then that's more of a challenge when we try to avoid epinephrine,
Sure.
lidocaine.
Sure.
So, but again, get them to us or to dermatology, not to me specifically, but definitely get to dermatology right away. Mhm.
Okay. Great. Excellent. Yeah. What do you got next?
I was going to talk about acne next.
Perfect.
Acne is probably one of my favorite, not, I shouldn't say favorite, but I just really enjoy treating all ages with acne, as it really impacts everyone so differently. And it can really make or break someone's confidence. So there's so many things associated with acne. So with acne, just make sure you get a good history with your patients. The key history things I would tell people is, for females, ask them if it's hormonal, are they getting premenstrual or ovulatory flares? Find out if there's like close members of the family with like a history of scarring acne. And then the next big thing is during your assessment. So often patients are concerned about their face. I can't tell you how often when you actually get to like the chest, shoulders, and back, how much more scarring potential is actually there. So it's just important to make sure, even if they don't bring it up, just make sure that you do check those areas, especially in teenagers. They start to become more bashful around their parents. Their shirts don't come off like in the summer as much, or, so it's really important to make sure we check. We find a lot of, unfortunately, hidden surprises back there. Okay.
Okay.
Um, Kind of the basics of acne. When you assess a patient, you really want to know, well, what kind of acne do they have? And then we can go about like what types of treatment we want to do. So kind of basics, we think of like the blackheads, which are like comedones, open and closed comedones. Those respond best with more topical medications, specifically topical retinoids, like Retin A, Differin gel. Azelix or azelaic acid is a really good one too. What's important with that is that gentle cleanser, always a gentle cleanser, and it's not a spot treatment. You want to do like a good pea-sized amount, like on your fingertip, make dabs around, and then treat the whole face. I find I get a lot of people say, well, I'm just treating the areas, but then they're not going to get the good repetition and then prevention of the new acne from forming. So I find that that's very key. One of the big things, and you'll hear me say this a lot with any topic, education is key. Topicals, topical retinoids can take 8 to 12 weeks to show max benefit. So it's most important to say we're going to recheck things in 2 to 3 months, because if you do follow up too soon, you say we've failed a medicine that we truly haven't, but also you're setting that patient up for disappointment. And I also find that, especially in teenagers, they may give up if you say that their acne might improve at this time, and then it's not improved, they're just going to stop using it.
Sure.
Proactive commercials say acne will clear in 2 weeks. And I just told everyone 12 weeks with topical retinoids. So it's hard when you have the commercials versus reality with prescriptive medicine. So education is really key. Okay. The 0.1% over the counter is one of my favorite options, because it's one of the most affordable products out there. And it's a great starting point. So, and it's fairly tolerable for most skin types. So that's usually one of my go-tos. The next type of acne are pustules and inflammatory bumps. So not quite the cystic lesions, but they're starting to be more visible, more red on the face. Retinoids, and again, that can be very helpful for it. But oftentimes when you start to see that, you're going to want to start using maybe like a topical antibiotic, like Clindigel, clindamycin solution, benzoyl peroxide wash, things like that can also be very helpful. If you recommend a benzoyl peroxide wash, the next piece needs to be of education, saying, make sure it can stain clothing and towels. So make sure, really wash up in the shower.
Absolutely.
That's a huge thing. The more you educate, the fewer angry phone calls you get. That's really my biggest piece of advice. And then you get into more like the deeper bumps, the cystic acne lesions. And when you see those, I usually will talk to patients and parents about I understand you may want to stick with only topical medications, and that's okay. But oftentimes, when you have cystic lesions, an oral medicine is usually always necessary, okay, to really show benefit. Depending on male, female, if there's hormonal components, that's when you can jump in with oral antibiotics, birth control pills. We use off-label spironolactone, which works really well for hormonal acne. And then eventually oral isotretinoin or Accutane is a really good option as well. What I would suggest in family practice, doxycycline and minocycline, I think, are two really great options as starter medications. I do see a lot of people starting with 50 milligrams for either of the dosing. And that's not a bad thing to do. But I also find that the 100 milligrams BID, you're going to get a quicker and better response. And then you're also going to have increased patient satisfaction. Okay. And I find that when you're starting out too, you really want to try to gain that trust. Like, I know what I'm doing. I'm going to get in with a good medication. And you can always lower the dose over time too. But I usually start high unless there's an intolerance to the medication. And I find that works really well. If there's allergies, you could always consider cephalexin, Bactrim. I use double strength Bactrim, erythromycin extended release, the 500. I can be an alternative due to allergies or sensitivities. And I think that in family practice, you'd be able to try those too. I don't think there shouldn't be too much hesitation with that. And then in women, you can use birth control pills if you're comfortable starting that. And spironolactone, honestly, in my opinion, of 10 years of dermatology, I find spironolactone is an undervalued medication for the treatment of acne in young girls through women. The nice thing about spironolactone is we don't even need to monitor potassium levels in healthy individuals anymore, where the AAD just came out saying it's not necessary, where we did that for many years, actually. So it's actually a lot safer. Oral medications, back to that education piece, really important to tell them 6 to 8 weeks to show max benefit.
How long are you usually dosing the for doxycycline, minocycline, and also the spironolactone? What dose are you using there too, and for how long?
Yeah, so the doxycycline and minocycline, I would do 100 milligrams twice a day, and then probably recheck them at like 6 to 8 weeks, depending when you can get them in your schedule. And then my rule is if they're doing well and they're not getting any new cystic lesions, we would either stay on that medication or maybe continue that medication and lower the dose to I'm so sorry, more of a less of a therapeutic or antimicrobial dosing.
Okay.
Oral birth control and spironolactone will take closer to 12 weeks.
Okay.
Absolutely. The last bit of acne I want to touch upon, kind of with the cystic lesions, and then you also have the nodular cystic lesions. Nodules are defined as greater than like 5 to 6 millimeters. Usually, when someone has nodular cystic acne when they walk into your office. Send them to derm right away. You can definitely get them started on an antibiotic if they're not already on one, but just get them to derm right away, okay? Antibiotics are usually not resistant, just not enough for the type of acne. And they typically do need like oral isotretinoin or Accutane. The other piece is if you see someone not just with the nodules, but anyone with scarring, again, I would send to derm, because if you want to have us explain to them the outcomes going forward, because that can be a challenging conversation. So.
Great.
Yeah. I'm trying to think. I'm just reviewing my notes here. So like I mentioned, just a few reminders. If there's any scarring, send on to derm. Keeping it simple. I find, especially with teenagers, less is usually more. Teenagers typically like pills, their parents might not, but try to keep it simple. Gentle cleanser, a good moisturizer, and then maybe try one topical, one oral. I find that that's best because it's simple and they can, kind of stay more compliant with that. And then again, go over expectations and timing. I go back to it. Education is so key with our patients. The more you educate, the less phone calls you're going to get.
Great.
Okay. Any questions, Luke, on acne?
No, that was excellent. Thank you.
Okay, so briefly, I want to touch upon warts and molluscum, two of my most frustrating things that I treat, which should be the most simple, but they're the most frustrating. So as you probably are familiar, warts and molluscum, they are both viral infections. We call them cousins, even though they're not the same virus, they're cousins. And they're difficult to treat because it's a virus. And again, I'm going to go back to education. I always tell my patients expectations because it's a virus. Any treatment that I provide for them, I can't guarantee it 100% it will be effective. The nice thing with molluscum is they're usually pretty self-limiting. I would say around 18 months to 2 years, unless they clear up sooner than that. But warts, I mean, we're talking decades. You just don't know how long they could last for. So some things, when I tell people, I'm actually a big fan of the over-the-counter treatments. I think Mediplast, which is like the little Band-Aid that you can just stick on your foot, that's one of my favorites. Even the sal acid, like the I'm so sorry. Just like Compound W, things like that are great. Again, it's the education where patients expect it to be gone in 2 weeks, where you might be using it for 2 to 3 months, and that's okay, and even sometimes even longer. I'm a huge fan of liquid nitrogen, but then again, you have to go back to the scarring component, location, the amount of discomfort, because it is pretty uncomfortable to have that type of treatment. But again, especially if there's like a few warts, I think liquid nitrogen is a good option. But if they're larger, I would go over again expectations that they might be coming in every 3 to 4 weeks to have it treated. And it's almost like $300 a treatment. I think it's like $270 for less than 15 warts, I believe. So it's just that cost for patients can really increase over time as well.
Sure. Yeah, is there a difference in cost between having dermatology do it and having it done in primary care?
That's a great question. To my knowledge, I don't believe so. I think the standard is the same. The only thing that might be different is if you had a patient with Medicare. I know that the Medicare bills at a different rate for NPs versus physicians, unless that's changed. I apologize if I'm off on the dates here. So that might be, but otherwise it's the same rate.
Okay.
Yeah. Again, if you're going to start with liquid nitrogen, it's typically the 3 10-second freeze thaw cycles. If you're I use the canister. I find that if you actually like pulse the gun, it doesn't expand the depth of the freeze as much, and it stays more local. That's one of the tricks that I've learned. I'm going to say more is better with liquid nitrogen because I find that most people undertreat. And if you don't even get like a scab or a blister, the patient's not going to be happy. So in liquid nitrogen for warts, like on the feet or the hands, more is probably better. And I don't say that often. Things that you can do for prescriptions. So one of the later research articles, oral cimetidine given in high doses. So in kiddos, we usually do like 300 per 5 ml, like 5 mLs twice daily. That can help stop the replication in both warts and molluscum. And the nice thing with that medicine, it's a safe medicine. People don't really have issues with it. So that would be something to try. And even by itself, sometimes we see benefit. Imiquimod or Eldera, traditionally used for like genital warts, some skin cancers. We do use that for both molluscum and warts as well. I find that they work better for like flat warts, common warts, not really the plantar warts, and it works great on molluscum. I dose Monday, Wednesday, Friday for molluscum just because I find the skin irritation is so much more, but a great option to try. Okay. And then in office, the liquid nitrogen, like I mentioned, there's different acids you can place on it. There's something called Beetlejuice, which is like a blistering agent. I would really caution that if you're not familiar with it, that can turn into, let's just say, a blistering mess. It can be really bad if you don't know what you're doing. And then there's also electrodissection and curettage, and then also cantharidin. Cantharidin is like a yeast agent that we inject into like a wart. And
Yeah.
it tries to stimulate, okay, I wasn't sure if you're familiar. It stimulates the immune system to try and fight off that virus. I haven't had the most luck with it in the last 10 years, but it's an option that I reserve as my last resort type of thing. And then some places they'll use what's called bleomycin. We're not allowed to use it because it's not FDA approved and we don't have a hood in our department, but you use like a bifurcated needle and kind of drip it on the wart and it just turns it black. I wouldn't advise that in family practice, but it is a really cool treatment. Okay. All right. And for warts and molluscum, refer anytime. I think in family practice, you have enough things to worry about just treating the whole patient that if you try something with warts and molluscum, you can just send them on over to, we don't mind. Any questions about that, Luke?
Yeah, has the cantharidin along with liquid nitrogen been used? Have I heard that before?
Yes, there are
Combination?
combinations of actually all of these. A few of my colleagues that work at Forefront, some of them use liquid nitrogen and the beetle juice or like the blistering agent, liquid nitrogen and cantharidin. Some people even will use an acid along with that as well. You can do so many things. I think it depends on the resistance of the wart itself. If you've tried different things, maybe the size of it too. I think it's probably dependent on that. So I think in family practice, you'd probably want to stick with one just in case there's a bad reaction. Like if you're using, because that's the problem with like the beetle juice and the cantharidin, they're great treatments, but there can be, people can get some bad reactions from severe rashes or swelling from it. So then you do that on top of the liquid nitrogen. I'd probably be pretty cautious with that.
Absolutely. Okay, great.
Oh, great question. Great question. Okay. So now I'm kind of dive into eczema and psoriasis. Am I okay on time yet, Luke?
Absolutely. Yep.
Okay. Okay. So with I put everything under dermatitis that I want to talk about. So dermatitis really just means inflammation of the skin. Under that umbrella, if you will, we have your classic atopic dermatitis, which is, traditionally like more like the pink, dry scaling areas, commonly found like on the AC and popliteal fossa, hands, body, more in infants and young kids, but also throughout adulthood. We do see some later onsets as well. So we always have to wonder when we do get even myself today, when I get a bad rash, could it just be eczema? That's always, part of our rule out process. The other part of dermatitis is nummular dermatitis. Nummular dermatitis, most of you will probably see if you haven't seen in rotations, or you'll be seeing it pretty quick in your practice, I would think. Nummular is defined as annular or coin-shaped patches, which have like a little bit of scale around, commonly to the arms, torso, legs, but really it can happen anywhere on the body. And I find that this gets misdiagnosed as ringworm all of the time. And one thing, and I might mention it later too, my thing with rashes, very seldom is it actually contagious. I would say if anything, put some triamcinolone on it. Most rashes are truly inflamed, not infectious, or I should rephrase that, fungal or yeast. They're most always inflammatory. So if you see multiple round patches, it's more likely like a nummular eczema or even like a thin plaque psoriasis. So just something to kind of keep in mind. The next type of eczema it has a few different names, dyshydrotic, vesicular, and then pompholex, which you'll oftentimes see on the hands, the feet, and even the ears sometimes. And this is one that I want to explain to you. I get a lot of different rule outs on this, so I think this is actually a pretty good one. When you see on patients, like it appears more like little small vesicles, blisters, or like almost like little bubbles on the hands and the feet. What happens is we don't have enough skin and fat tissue on those locations. So the skin swells and presents those like blisters and bubbles. A lot of times, and And to a great differential diagnosis, people think that patients have herpetic whitlow, which is like herpes of the hand, and great differential diagnosis. Again, I'm always proud of those people, but it most oftentimes is the hand eczema or the vesicular hand eczema. I tell people, if you're questioning if there's a herpetic component, just treat them with Veltrex. It's not going to hurt them. Veltrex is very well tolerated, but I would add that topical steroid on there as well. And I find that you'll probably get benefit and a happy patient. So that's probably one of my bigger takeaways. And two more parts of my dermatitis here. The other big one is contact dermatitis. Contact dermatitis in urgent care and family practice, you're going to see a lot of. Always listen to history. It's not necessarily new products, though. I think that's a big misconception. We can use the same products for years and develop a new allergen, and it can be frustrating because we're trying to identify. So contact dermatitis can really look like anything, but commonly you'll see it to the hands, the neck, the chest. You might even see like outlines of straps where things aren't hitting or where they are hitting. Eyelids, scalp, and neck are the big areas. I tell people, if you see the rashes there, you always have to say, could this be a contact as well? Okay. Treatments for that. And I'll get into steroids if I have time in just a little bit, but steroid medications, the one thing with steroids, making sure you get the appropriate steroid for the appropriate location. I have patients that sometimes come in frustrated because they get an ointment and they have longer hair and they're trying to put an ointment on their scalp. And, we could very easily give them like a solution or like a lotion. The lotions actually are great alternatives. They're less, what is the word I'm using for? They're less alcohol content, so it doesn't burn the skin as much. So the lotions are a great option for the scalp. Ointments for the eyelids are perfect. The eyelids are some of the most sensitive skin on the body. And if you put a cream on it, so oftentimes it's going to just burn and cause significant irritation. So just something to think about. Trunk and extremities, you can put a steroid cream, ointment, or oils actually work really well, especially in the kiddos, I have found. So there's lots of treatments that we would do in dermatology, phototherapy, oral methotrexate. There's a new injectable called Dupixent. And then again, if we're considering a contact dermatitis, we do patch testing as well, just to exclude and find out their allergens. The biggest takeaway with eczema is moisturize, moisturize, and moisturize again. Aquaphor, CeraVe, like O'Keeffe's Working Hands, things like that. Those are my favorite things. Don't be afraid to get a steroid started and make sure that they have enough. That would probably be the other thing. Sometimes I have people with head to toe eczema and they hit a 15-gram tube of whatever the medicine. And I'm like, well, you're steroid deficient and you poor thing, you can't even treat yourself. So just make sure that, and I even sometimes tell patients, because sometimes it's not on the clinician, it's the insurance or the pharmacy decides they may only need a 15-gram tube. So I always tell my patients too, if they need like a tub of or a pound jar of triamcinolone, just tell them when they get to the pharmacy, if that's not what they think it should look like, to call our office, and we can always change the orders around. Again, I'm going to go back to education. Control versus cure with eczema. A lot of times I find patients come in and they'll say, well, the medicine didn't work. And then I'll go back and say, well, did it clear up your skin? Well, yeah, it cleared, but then it came right back. So I tell people, well, that's normal. So then we just tweak the medicine around to help prevent a bad flare again. So just, again, education and control versus cure is one of the most important things too. It's not technically eczema, but just briefly, seborrheic dermatitis, seborrhea, or cradle cap in kids. It's an overproduction of yeast on the skin, but it becomes inflamed. So oftentimes ketoconazole, shampoo for the scalp, even ketoconazole cream for the facial area is perfect. But more than not, they do need a topical steroid on board. Again, not every day, but really to help calm things down. If you feel comfortable on the face, having them use over-the-counter cortisone, even that's good enough. Sometimes they may even need prescriptive hydrocortisone 2.5% for the face, or again, like a betamethasone valtrate lotion for like the scalp, things like that. So I just wanted to mention that because that's a very common condition. You'll see that on the scalp, the like glabella brow area, the nasolabial fold, and then people with like beards or mustaches, you'll see it commonly in those areas, and then the ears if I didn't mention that. Okay. Any questions on that?
No, that was excellent.
Okay. Excuse me, I just need a sip of water. It's allergy season for me. Okay, and then my next topic is going to be, I just have a few topics left, so bear with me. I hope I still have time. One of my other very passionate conditions is psoriasis. Both my husband and I, we do have psoriasis. So I can really appreciate when a patient tells me they're miserable, they're itchy, they're embarrassed. You know, psoriasis, like acne or eczema, it just really plays a role on people's confidence, maybe their sleep, so many different things. So if you do have a patient with psoriasis, let's say they walk in and they have the classic elbows, knees, you know, we know it's a psoriasis diagnosis. One of the first things I would tell you to do is ask your patient if they have joint pain, swelling, or stiffness. 30% of people with psoriasis either have or will develop psoriatic arthritis. I think the statistic says 15% of people with psoriasis don't know that they have psoriatic arthritis, but they do. The reason it's so important is to preserve joints. That's one of the big things. But also in patients with psoriatic arthritis, their heart disease rate doubles in these patients. So it's really important to identify that so then we can align them up with the appropriate providers, whether that's, you know, someone like you in family practice or setting up with cardiology, you know, depending with screening tests, things like that. I ask every one of my patients that has psoriasis if they have joint pain. If they do, regardless if I can differentiate if it's a little wear and tear or something else, I even refer to rheumatology. I just would prefer not to miss something like that. Things when you're looking for assessment, I think psoriasis can be very classic when you think of like the scalp, knees, and elbows, but you can also get other forms. There's guttate psoriasis. When you have a new rash, you know, if you hear of a patient say that they had like a bad sore throat or an illness, psoriasis should always be in the back of your mind of what it could be, okay? A few things about psoriasis. Topical steroids are probably what, sorry, my phone's going off, would probably be what you'd want to get started in practice. And I think it's reasonable in family practice to get something started and recheck them. And with the goal in mind, if things are going well, they can keep using those things. But then if not, say, let's try something different, or just get that referral placed, or you can start something and send the referral, whatever your comfort level is. And again, I mentioned before, always read the referral notes because that's how you can learn the different products and over time be more comfortable and confident in prescribing medicines outside your box, okay? So again, like the topical steroids, solutions, ointments, creams, depending on location. Another medication is calcipotriene, which is a vitamin D derivative. So kind of like sunshine in a tube. It works great. There's no addictive features. There's no skin thinning. So it's a great product to consider. Cost, it can be a little pricey, although it is generic. So that's the only thing. And then we have a lot more advanced products in dermatology, such as methotrexate. There are biologics coming out every month. So the nice thing for patients with psoriasis is you can tell them that we'll likely have something for them. Clinical pearls. I personally believe it's okay to refer at any level. I don't think anyone would ever say you referred too early with psoriasis because psoriasis can affect, again, as I mentioned, people very differently. So they may want to go on a biologic, even if it's only affecting a few areas. So something to consider. Control versus cure, again, the education piece. And then the big one, if you are suspecting psoriasis, never, ever prescribe oral prednisone, okay? The major issue with that is it's very rare, but it can actually trigger a pustular psoriasis flare in patients, which can lead them to hospitalization and worst case death. Again, it's very rare, but if you're suspecting psoriasis, I would avoid prednisone. Low dose, like if they're having like an asthma issue or some type of cold that's different, but I'm talking like longer use, you don't want to use. Okay.
Okay.
Any questions on that?
No, I think that's a really good point. You know, you always kind of think with psoriasis, one of the things you worry about is inflammation. So with steroids, but oral steroids, and what you're saying is contraindicated.
Yeah, and I say that, and you might see in some of our notes or in rheumatology, you may see that. And we do it very rarely. Rheumatology does it more than us, or I say us in dermatology, but in family practice, I would avoid doing that unless you absolutely have to. So that would be my probably the biggest takeaway with psoriasis, that and asking about joint pain. Okay. All right. I briefly want to talk a little bit about rashes. It was hard to decide what to talk about tonight, just because I have the gift of gab, as you can tell, but also there's so many different things. So I want to highlight a few different things with rashes. And if anyone ever has specific questions, let me have them. I'm happy to go over any types of specific rashes. So the biggest thing in family practice, you really want to focus on your history, timeline, locations. Sometimes certain areas might flare first. Pityriasis rosea is one of the most common. Like, did they get a first lesion here? Do they have any symptoms like sore throat, a bad cold, a fever? Sometimes the history in itself can diagnose the problem. An assessment, going over assessments with varieties of different rashes, I always find with students that describing a rash is probably the most difficult thing. And sometimes even I'll look at something and say, you know what? I'll take a picture and say, see photograph. I get it. So I tell people, I'm not going to go over how to describe rashes, but more of, don't worry about writing it down. I tell people, look at what's in front of you and what do you see? Are you seeing well-demarcated lines? Are you seeing like little pimples or pustules? Do you see vesicles? Like, just look at it, worry about the documenting piece later. I always find the documentation of rashes for students was most difficult. That I don't know if that still holds true, but it was for me when I was a student. So just really look at it, okay? Always look for classic signs. Shingles is a big thing. In dermatology, I actually don't see shingles very often. They typically go to family practice and urgent care. My biggest takeaway with shingles is if you're suspecting it, treat it. Some people I've seen get a culture and then they'll wait to treat it. Please don't do that. If you're suspecting, get them on Veltrex. You can still culture it, but just start treating right away. If you are questioning impetigo or a secondary infection, again, treat it. And tinea. One thing, I know I said before that most rashes aren't contagious, and I'll still agree to that. Rashes to the feet. Now, this is a different story. When you're looking at a rash to the foot, always look at their toenails. Now, you can look at nails to overall. But if you're suspecting there could be an onychomycosis or a fungal nail infection to the toenails, assume that they have a tinea pedis, okay? Now, they might have something underlying, but you're probably going to want to get an over-the-counter terbinafine cream on board. So always make sure you check the toenails too, okay? Even though the patient's not complaining about it, that I always find is a key sign to help with the diagnosis. I mentioned most things aren't contagious. I mentioned with the nummular eczema gets confused with like tinea rashes. Things that I want people to send urgently. If you look at a patient when you walk into that room and they have large like bullae blisters, call us or call dermatology. Whoever in your group is your go-to person, you're going to want to call that person. Okay. They should probably be seen pretty urgently, as that could be some type of significant autoimmune disorder or some type of erythema multiforme major, something to that effect. The other thing is if you have a patient that's completely red from head to toe, we call that phrase erythrodermic. You really want to make sure that you call someone in dermatology and send a stat referral for that as well, okay? Stevens-Johnson's, blistering rashes. But if you look at a patient and you just get that gut feeling and you're like, I think they need to be seen today or tomorrow, just call your local derm person and just explain what you see. Photos are great. And I think our dermatology department, as I'm sure others, are very good about getting people in. Okay. Last thing, if you think they have scabies, treat them for scabies, because if you miss it, they will be miserable until you get that diagnosis right. I'm guilty of it. I've missed it. There are some atypical presentations of scabies, and I fell victim to it more than once. I'm ashamed to say it. So if you're questioning it and you have an itchy patient, just treat them for it. I wanted to mention steroids. There are so many different medications that you can choose from. I tell everybody, pick a few, like one in each class, and just use those. Get used to them, get familiarized. Sometimes the insurances, like the Medicaid, Medicare formulary list, change every quarter or year, it seems. So then you can alter it pending that. But otherwise, I just tell people use the same. I use like a hydrocortisone or a desinide for the face, Triam 025 for like the groin or inframammary region. And then you can kind of go up from there. But I tell people there's no need to get fancy with steroids. Just pick generics. Get associated or familiar with the ones that you like and just stick with them. Okay. Do you have any questions about steroids, Luke?
Yeah, I mean, what are kind of you were saying triamcinolone, desinide, what are the other ones that you really kind of prefer and regions of the body too?
So for like the sensitive skinned areas, I'm very fond of the hydrocortisone 2.5%, desinide or desoin, and then the triamcinolone, the 0.025 concentration. They're kind of in that same like low class, low potency level. Jumping up a level would be like the Derma-Smooth, like body oil, the triamcinolone 0.1%. I'm so sorry. Betamethasone, Valtrate, things like that are going to be the next ones. Bumping up a class would be like fluocinamide. And then you're going to have your high potencies like betamethasone dipropionate and clobetasol. You may have heard me say betamethasone Valtrate and betamethasone dipropionate. That's why I stress the importance of learning like a few in each class and just using those, because those are two examples of what one could consider could be the same thing, or, it can be hard. And when you're busy in practice, you're like, okay, let's pick that one, or, it can be a little tricky. And then there's halbetasol. There's just so many. So if you actually Google, I think it's under the Forward Healthcare formulary, that's kind of what I go off of, honestly. And you can just look at the different class steroids and you'll see what I'm talking about. And that's why I just say pick the ones you use, or if you have a mentor or someone you're working with, if they prefer certain ones, it's definitely okay to stick with those and just use what you become comfortable with. Okay. Okay, I have a few last things and I think I'm truly done. Okay, so I mentioned to make sure you read the consult notes. Again, I can't stress that enough. With your first job, not even first job, whenever you get a new job too, it's always good to see within the company that you work with if there's different shadow opportunities, if they're allowing you to work with different specialties for additional training, exposure. A lot of times, I think for our company, when they start, they're on some type of guarantee salary. So there's not like a certain quota of patients that you have to see. So I know that people like travel around. That would be one thing that I would encourage you, or even when you're interviewing, to ask if that you're allowed to do that, because I think that you can get some significant value from that. Not necessarily, well, not only dermatology, but so many more things. And actually, Luke, you touched upon it. Explore it with the hands-on workshops and procedures if you're interested in it. When I was in grad school, I think we learned on pigs, I don't remember, a pig foot maybe, I think is what we did. And then I learned to sew on my pillow at home on my couch. So there's different ways, but I'll look at more workshops, but I'll send you the links later, Luke, about different places. I don't know, I'll look to see if there's any local workshops too.
Okay, great.
Okay, I think that's all I had. What questions do you have for me?
Yeah, one of my favorite topics is you get a patient in your schedule and the chief complaint is bugs. Do you have
Oh,
any recommendations as far as everybody treats it a little bit differently, but what's kind of your
my approach.
things? Yes.
So are you referring to like delusions of parasitosis or just the contagious nature of head lice and bed bugs, things like that?
All of it.
All of it. Okay.
Yeah.
I just have to grab a cough drop here.
You were talking about things not being contagious, and that's always one for people when they come in concerned
Mhm.
about bugs. That's always, is this a contagious, something contagious that I have to worry about? I have to worry about an infestation.
Yeah.
So,
That's a great question. Okay. So in my practice, the one thing I do not see is head lice. If there's a referral for head lice, I have a fear of head lice. We actually call it flice. You guys can shake your heads at me. I don't even care. My schedulers, my nurses, they know if anyone puts someone in my schedule, they're coming in the room with me because I do not see it. um, that's just a me thing. In regards to bed bugs, um, people coming in with bed bugs really aren't necessarily contagious because the bugs they're not on the people. So we treat the bites. So we're going to give them like a topical steroid. I will sometimes even do a topical permethrin if they feel they need a treatment. Sometimes I treat what the patient needs as well. So if the patient feels that the bugs are inside of them, we sometimes treat with permethrin, sometimes with bed bugs or the thought of having bed bugs. The one thing that I'm concerned about would be head lice and fleas. I had one patient who came in with Uniboot wraps on, and when we took them off, he had fleas coming out of the wraps. So that we had to shut the room I can't remember if we had to that was a while ago. If we had to shut our department down, there was a whole cleaning process for that. But for like the bed bugs and fleas, you really have to just tell them they need to get their house bombed because the skin is secondary to the actual problem. So they need to fix the problem in their house, if that makes sense. In regards to delusions of parasitosis, if you want to get close with anyone in dermatology, don't send delusions of parasitosis. It's not a dermatologic issue, it's a psychiatric issue. Now, in the defense of anyone that sends that, we get it. Oftentimes the patients don't believe their provider, and that's going to be in family practice, it's going to be in derm. I work with two doctors, and the three of us kind of have the same approach. Respectful and kind, but also open and honest. You have to listen to their story. You need to be understanding of their story. And after we listen, after I do a thorough exam, I will sit with the patient and I will have that open and honest communication and say, you're not going to like what I have to say, but I don't think that you have this. And then I start to explain what I think is going on. And then I usually follow with, I would like to send a referral to. If some people believe you, we will go right to psychiatry if they don't already have someone on board. Otherwise, unfortunately, we do utilize the University of Wisconsin-Madison and Froedtert a lot. I don't think they like us very much for it, but they used to have a dual-boarded dermatologist and psychiatrist down there, and she's no longer there. Her name was Dr. Mash Dagami. So if anyone finds her, let me know where she is because she was fabulous. The medicine that's oftentimes needed, there's a lot of cardiovascular risk, so a lot of EKG monitoring, so we don't get into it. And I don't know that it's our place to get into either because, again, it's secondary. But you bring up a great point too. And one of the things what my mentor, Dr. Holder, has always taught me, never assume a crazy person's crazy because crazy people have crazy things. And I think that's a very important lesson. Whether if something walks into your room and you are having the worst day of your life in your career, you still need to take every patient's valid complaint. And in my world, I have to think, okay, is she really just seeing bugs? Does she have something is there a tumor? Does she have like some form of cancer somewhere? We still do a thorough evaluation. But if we truly aren't finding anything, then it's time for for us to say, we want to help you. This just isn't the right place.
yeah, absolutely.
Yeah. Did I answer that okay?
Yeah, I think that's one of those things, primary care wise, you often get well, I think it is, and you're trying to explain the patient, I'm not seeing anything here. So the
Mhm.
question is, do you refer to somebody else knowing that it's likely more of a mental health issue? That's a very complicated, but having those honest conversations is definitely something that can be done in primary care, or at least
And
started there.
off of what you said, I don't mean to interject or interrupt, rather. I think it's still appropriate to send to dermatology because sometimes the patients need that. It's not that they don't trust or think you're right, but and sometimes you can set the stage by saying, I think dermatology will agree with me. We can have them weigh in. And I think that's a great way to set the stage. And then that way, if the note says discuss with patient, then we can just reiterate and say, now I know Luke talked to you about this, and I actually agree with Luke's assessment and think that this would be the better place for you to be evaluated. And it's incredible. If you've ever worked with anyone with delusions of parasitosis specifically, it is it's one of the more challenging things that we see because you can talk them through and through and they will not believe you. And one of my colleagues relatives ended up having delusions of parasitosis triggered by some medication in the hospital. I don't recall what it was. And she's like, I never believed people until my husband had it. It's a horrific thing to go through. And you also have to be compassionate towards their significant other or loved ones at home because they're also dealing with that same thing because they too don't see the bugs. And sometimes I think they eventually just give in to the person struggling with the delusions as well. So. Mhm. One thing, just because we're in the middle of a pandemic, please don't send delusions of parasitosis to infectious disease. Send them to us. We'll take that burden off their plate.
That's an excellent point.
We'll take that. So
Yeah, well, this was excellent. I don't know if you have anything else that you feel is important for the students, but it really, I thank you so much for doing this. This was really very, very helpful.
you're most welcome. I actually really enjoyed this. I hope Luke tells you later. I didn't realize I was being filmed for the class, so I wasn't prepared. I've been up since about 5 this morning, so I apologize. But I really enjoyed this. If you have any follow-up questions with anyone in the class, I don't mind going over any questions. If you guys have any specific cases or if you have any follow-up or reach out you need, just let me know.
Great. Well, thank you so much, Andrew. We appreciate it.
Absolutely. Good luck to everybody.